In this lecture, we will be discussing Chapter 6. At the end of this chapter, you should be able to describe the Medicare prospective payment system for acute care inpatient, define basic language when we talk about inpatient prospective payment systems, and identify the components, the adjustments, and the provisions of the MSDRG and the steps for assigning an MSDRG. And finally, recall the payment determination for the inpatient prospective payment system. Chapter 6 is divided into two different lectures and two different PowerPoints. This one is the first one. The inpatient prospective payment system is for acute care facilities, hence the name inpatient. So it's for hospital inpatient. It excludes psychiatric units, long-term care, and rehab units. Those we'll talk about coming up in the class and will be covered in a different section. Their effective period is October 1 to September 31. They're updated yearly. So when we talk about why Medicare implemented a prospective payment system, basically legislators were demanding that healthcare costs be controlled. So before the inpatient prospective payment system, there was, it was really a fee-for-service environment. So if a patient was admitted to a hospital, it wouldn't matter how long they stayed, how many tests were ordered, whether they were necessary or not. Medicare just paid those claims. So as you can imagine, costs skyrocketed. So this was really the government's initiative to try and control healthcare costs. So as we talked about, prior to prospective payment systems, Medicare hospital inpatient claims, they were reimbursed on cost of services, reasonable cost, and also per diem cost. So basically that meant that a hospital was reimbursed for about 80% of its costs for treating Medicare beneficiaries. From the hospital's perspective, there was really no incentive to try and reduce the cost. If there was cost associated with the patient care, those costs increased, so did the payments. So by the late 70s, healthcare costs, hand in hand with reimbursement from Medicare, sharply rose, as you can imagine. So that really impacted the dollars that the Medicare program had in reserves. So by the early 70s, Medicare administrators really began to search for a different payment mechanism to help try and control the rising costs. So the system that they began to investigate was based on the concept of prospective payment. In 1972, Congress authorized CMS or Medicare to begin prospective payment demonstration projects. So why were they moving to prospective payments? All the reasons are listed on this slide. It was an incentive for hospitals to operate more efficiently. The prior 3 years, Medicare payments had increased 19%, or 3 times the rate of inflation. The deductible for the Medicare beneficiaries was on the rise, as were healthcare costs, like I said, draining the Medicare funds. No monies were available to fund other programs. Hospital payment rates really varied from place to place for the same exact service. And to eliminate the burdensome reporting requirements. So between 1972 and 1983, Connecticut, Maryland, Massachusetts, New Jersey, New York, Rhode Island, Washington, and Wisconsin implemented prospective payment systems by participating in demonstration projects. So based on the results of those projects, the prospective They found that the prospective payment systems were effective in reducing the rate of increase, so how fast those were increasing hospital costs. Small rural hospitals were given special exceptions, as still is the day today. Case mix levels must be considered. And they also found out that hospital costs could be controlled while still providing adequate reimbursement and adequate care for the patients. Because of the success of those demonstration products, the Tax Equity and Fiscal Responsibility Act of 1982, or TEFRA, mandated extensive changes to the Medicare program. Many of those changes, as you can imagine, focused on controlling rising costs of health care. TEFRA called for implementation of a prospective payment system for hospital inpatients. The adopted classification system was from New Jersey's demonstration project, and they used what we know as DRGs, or diagnosis-related groups. The implementation date for DRGs in the U.S. was October 1 of 1983. So the DRG system takes into consideration the role that a hospital case mix plays in influencing the costs. So each DRG is assigned a relative weight, or what we call RW. DRGs were developed at Yale University in the 1970s. As we talked in the earlier slides, why DRGs were developed was to really establish an effective framework for monitoring the quality of care that patients were receiving and the utilization of services to prevent under and over utilization. So what are DRGs? Really, that's a system that takes into consideration the role that a hospital's case mix plays in influencing the cost. A case mix index, this is an average of the sum of those relative weights of all patients treated during a specific time period. A case mix is defined in different ways based on one's own healthcare perspective. So from a physician's perspective, case mix complexity or description of the population can refer to the severity of illness, their prognosis, how difficult they were to treat. So that viewpoint would look at sickness as a proximity of resource consumption. But from the DRG perspective, case mix complexity is a direct measure of the resource consumption and therefore a direct measure of the cost of providing care to a patient or a group of patients. A high case mix in the DRG system means patients are consuming more resources, therefore the cost is high. However, it's a weak measure of severity of illness, what is their possibility of death, the prognosis, and a difficult treatment. So therefore, the case mix complexity viewpoint allows DRGs to be an adequate system for hospital reimbursement because it really measures the resources consumed for clinically similar patients. DRGs were the first system that allowed us to measure the case mix complexity. As we talked about, that's a direct measure of the resource consumption and therefore the cost of providing care. In order for DRGs to be practical and meaningful, the system needed to meet the following four criteria. Criteria number 1, patient characteristics used in the definition of DRGs should be limited to that information routinely collected in all hospital abstracting systems. Patients are grouped into DRGs based on the items listed here. If they are around the same age, not exact ages, but an age range, what's their discharge status? Did they go to a nursing home? Did they go home? What's their principal diagnosis? Do they have complications or comorbidities or CCs? What procedures did they have? So those are criteria number 1. Criteria 2, there should be a manageable number of DRGs, which would encompass all patients seen on an inpatient basis. Criteria 3 is each DRG should contain patients with a similar pattern of resource intensity. So each DRG group has a set payment rate that's based on what is the history of charges and of payments received. And finally, criteria 4 was that each DRG should contain patients who are similar from the clinician's perspective. So DRG assignment is primarily based on the diagnosis and/or the procedure performed. Effective October 1st, 2011, the DRG system moved to Medicare Severity Diagnosis-Related Groups, or MSDRGs. That's it has a reasonable number of groupings for hospitals to evaluate and manage. It was considered a fully packaged system. One DRG is assigned per admission. Costs for all services are included in the payment for one DRG. So whatever a hospital is paid for that one DRG, the hospital will either take a loss and not be able to recoup that money from the patient, or they will make a profit. So if the DRG pays less than the cost of actually caring for the patient, they will lose money. But if the cost for treating the patient is less than the MSDRG reimburses, the hospital keeps that money and then therefore makes money on that patient. So the hospital really has an incentive to try and control costs. You've probably noticed that hospital stays have decreased dramatically over the last few years. Used to stay in the hospital for a week to have a cesarean section when having a baby. Now they're out in a day or two. So that is one of the shifts in healthcare that has happened as a result of DRGs. So as we started talking about earlier, DRGs shifted to MSDRGs because there was criticism that the DRG system, really over the years, there was a lack of severity. So many people believe that refinement was necessary for Medicare to be able to adequately reimburse a facility for complex or really resource-intensive cases. So the MSDRG system, that's a refinement of the DRG system. It uses major complications or comorbidities, or MCCs, and also then our complication and comorbidities, or CCs, those diagnosis codes that DRGs used as well. You can see from this diagram that this is the breakdown of how we end up with a DRG. And how we end up with a DRG is really based off your codes. So if you code procedures or diagnoses for hospital inpatients, you are determining what MSDRG a patient would fall into and therefore determining their payment. So to start with, we look at what major diagnostic category they would fall into. So all DRGs are associated with MDCs. So maybe they fall under MDC 6, which is a disease or disorder of the digestive system, or MDC 11, which is any disease or disorder of the kidney or the urinary tract. So that is how MDCs are broken down. Currently, there are 25 MDCs. From there, you are split into either a medical section or a surgery section, and that is determined by, did you have a major surgery in this hospital admission? If you did not, you would move to the medical section. If one was performed, you would then move to the surgical section. And from there, then they look at other characteristics that we talked about on the slide that talked about all the criteria that determine a DRG. In order to assign an MS-DRG, we need to collect PHI, or patient health information. We need our principal diagnosis and just one of those. We can have up to 25 additional diagnosis codes. We can have one principal procedure and up to 24 additional procedures. So for our coding, it's very important to go by our official coding guidelines when assigning principal diagnosis codes. We also need to know the patient's age, sex, and their discharge status. We talked a little bit about this already, but as I said, they are given an MDC, Major Diagnostic Category Assignment. They are then looked at if they are medical or surgical, the length of stay, the relative weight is still in play today, so that's a measure of the intensity for a specific type of encounter. And then our code is going to drive the final DRG assignment. So this is an example of MS-DRG information for 2013. So this patient fell under 291. They fell under MDC number 5, which means they had a disease or disorder of the circulatory system. So that is determined again by the diagnosis codes assigned on the chart. And the length of stay is 4.7 days. The relative weight was 1.5174. And then you can see all the codes that were assigned to this patient. So why did we move to a severity adjusted system or from DRGs to MS DRGs? MedPAC recommended that Medicare refine the current DRG system in order to capture severity of illness. So the old DRG system really, a patient could fall under the same DRG, but that patient may be much sicker than the average patient that falls under that DRG. So they wanted to capture those very sick or very resource-intensive cases and get more reimbursement for those patients. MS-DRGs, some of the basic information, were effective October 1st, 2007. There were 751 groups as of 2013. As I talked about, MS-DRGs look at both complications and comorbidities, but also MCCs, which are major complications or comorbidities, which would make that patient much sicker. Development of MS-DRGs was a three-step process. We needed to consolidate existing DRGs into base DRGs. We needed to categorize each diagnosis into either an MCC, a CC, or a non-CC. Subdivision of each base DRGs was then put into subclasses based on those complications or comorbidities. These are some of the things that were looked at when they were revising the criteria or categorizing each diagnosis code. Does the condition require extensive monitoring of the patient? Does the condition that the patient has result in very expensive or complex services? Or does the condition result in extensive care that requires a greater number of caregivers than normal? What was removed from the CC list? Chronic diseases without an acute manifestation. So if the patient is in for kidney pain, for example, or kidney disease, and they have CHF, but they are very well controlled, there's no flare-up, really they're not doing anything in the hospital stay for the CHF, it would not be considered a CC. What was revised was significant acute diseases, exacerbations of chronic diseases that would require treatment and evaluation, and chronic diseases associated with extensive debility. So in order for those subgroups to be created, 5 criteria had to be met. A reduction in variance of charges of at least 3%, at least 5% of patients that fall under that MSDRG have a CC or an MCC, at least 500 cases are in that MCC or CC group. There's at least 20% difference in charges, and there's a 4,000 difference in average charge between the subgroups. This slide is just an example of a few of those subgroups that were created, and you can see the relative weight differences among those. So now we'll walk through how to assign an MSDRG. Step 1 is what we call pre-MDC assignment. This step was added during version 8 revision of DRGs. A set of procedures was identified that crossed all MDCs. The principal diagnosis is not considered for MSDRG assignment. Rather, the principal ICD-9 procedure is used to assign MSDRGs. Step 2 is MDC determination. So what is the principal diagnosis? As a review, the principal diagnosis definition is the condition established after study to be chiefly responsible for causing the admission to the hospital. Step 3 is, was an operating procedure performed or not? If one was, then they would be assigned a surgical status. If not, they would fall under the medical status. Step 4 was refinement. Various questions are used to isolate exactly which MSDRG that the patient should fall into. This process allows the MSDRG system to group together like patients from a clinical perspective with like resource consumption. So again, the things we talked about already, is there a major CC? Are there other CCs? Is there a major complication or diagnosis present? What's the patient's sex, discharge, disposition? And for neonates, what is the birth weight of the baby? This is just some definitions for you here. A complication defined is a condition that arises during the hospital stay that prolongs that stay by at least 1 day in about 75% of cases. A comorbidity, that's a pre-existing condition that the patient comes in with, that the presence of that condition will increase the length of stay by at least 1 day in 75% of cases. There's some examples in your textbook that you should go through, and they will help you have a better understanding. The MSDRG system uses provisions to provide additional payments for specialized programs and unusual admissions that historically have added significant cost to patient care. Without those additional payments associated with the provisions that we'll talk about in the next few slides, it may not be feasible for acute care facilities to provide all services to Medicare beneficiaries. But the inpatient perspective system really provides a single payment for each inpatient encounter. The first provision is what we call disproportionate share hospital status. That was enacted for facilities with a higher percentage of low-income patients. Additional payment is provided for these hospitals because they experience a financial hardship by providing treatment for patients who are unable to pay for the services that they receive. There are two methods of qualifications for this provision. First, a hospital has to qualify by exceeding 15% on the statutory formula. That formula takes into consideration Medicare inpatient days for patients on Part A, Medicare Advantage, or supplemental security income, and the total inpatient days for patients eligible for Medicaid, but not Part A. The second method for qualification applies to large urban hospitals. If a large urban hospital, if they're able to demonstrate that more than 30% of their inpatient care revenue comes from state and local governments, then they may be granted the DSH status. Approved teaching hospitals are provided with an indirect medical education adjustment, or IME. The hospital must have residents that are in an approved graduate medical education program. Teaching hospitals often experience an increased patient care cost in comparison with non-teaching hospitals. Therefore, Medicare provides this IME with additional reimbursement to help offset the cost of providing education to new physicians. Because the Medicare payment for inpatient services is prospective, hospitals will experience profit or loss on individual cases where reimbursement exceeds or falls short of the cost that we already talked about. The payment provided to facilities is an average amount. So again, they'll win some, they'll lose some. So for the most part, costs are covered if the care is managed appropriately. However, there are extreme cases, or what we call outliers, for which the costs are very high when compared to the average cost for patients with the same MSDRG. The outlier payment provision provides for some financial relief for some of those cases. A cost outlier, as defined, is the hospital's cost for a case, and they have to exceed the threshold limit established for that year. For 2013, it is $21,821. New services or technologies are often very costly. A new technology is an advance in medical technology that improves a technology that was previously available. Applicants for a status of new technology must submit a formal request, including a description of the technology and the results of any clinical evaluations that they have completed. Providing innovative services in a prospective payment system could, in many cases, lead to inadequate payment. So these financial losses may prohibit a facility from trying new and innovative services to patients because it's simply not affordable. So this provision helps grant some of that payment back to the facility. They would receive the full DRG payment plus 50% of the cost of the technology or service. As part of the DRG system, a base payment rate is established for each Medicare participating hospital for each fiscal year. The base payment rate is a per encounter rate that's based on historical claims data. The standard amounts are derived from 1981 hospital costs per Medicare discharge figures. The 1981 costs established the base year amount that were adjusted to explain differences among case mix, wage rates, and all those other provisions that come into play. The base year amount has been updated every year since 1981. Each year, the standardized amount is divided into a labor portion and a non-labor portion. The labor-related share is adjusted by the wage index for the hospital's geographic location. The non-labor share is modified by a cost of living or COLA adjustment. And the COLA is for Alaska and Hawaii only. So on this screen we have the adjustment calculations. These are some examples for fiscal year 2013. So simply put, we have the relative weight times the base rate plus provision payments. That gets us the hospital reimbursement. So now that we have our MSDRG assigned, how do we get paid? So our claim would be submitted to the FI, or the fiscal intermediary. The MSDRG is assigned with grouper software that's based on all that information that we've been talking about in this slide. So you probably will not see ever any DRG assigned by hand on paper. That's all assigned with software that we use today. But the history of that and the knowledge of what actually goes into play is beneficial. Step 2, the initial payment rate is established. The facility's specific base rate is used for payment, as we talked about. Step 3, if any of these apply, the high cost outlier or a new medical technology, those are added on if applicable. There are two types of transfer cases under the inpatient prospective payment system. One is a transfer between two hospitals, and the second type is a transfer from a hospital to a hospital or a unit that is not part of an inpatient prospective payment system, so a non-acute care setting. So what happens when a facility starts at one facility and goes to another, and they're both participating in inpatient prospective payment system? The transferring hospital receives the per dime payment. The MSDRG is established for the case, and full payment rate is calculated. This payment rate is then divided by our geometric length of stay established for that DRG, thus creating a per dime rate. The transferring facility receives double the per dime rate for the first day, plus the per dime rate for each day after for the patient's length of stay. The receiving facility will then receive the full prospective payment for the case. The only exception is for neonates who died or transferred to another acute care facility. In a type 2 transfer, and again, that's when a transfer occurs from an inpatient prospective payment system hospital to either a hospital or a unit that is not part of the prospective payment system. For that type of transfer, the full prospective payment system payment is made to the transferring hospital, and the receiving hospital or unit is paid on a reasonable cost basis or under a different prospective payment system for that setting. There are exceptions to this policy, and those are known as PACT, or post-acute care transfer policies. And those are for type 2 transfers. So why have a post-acute care transfer policy? It's to avoid providing an incentive for a hospital to transfer their patients to another hospital early in the stay in order to minimize cost and still getting the full DRG payment. And also to avoid paying two full patients when the complete course of treatment is divided between two facilities. And on this slide, this is just an example of a post-acute care transfer policy for a patient that has plural, a fusion with a CC. CMS, or Medicare, is responsible for updating the MS-DRG system each and every year. That is published in the Federal Register each May. Comments are received, taken, and then the final rule is published in August, addressing all the comments from the May publication. You can find the proposed and final rules on the Medicare website, along with the files that are for public use, and the website is listed here.